All right, so now we're going to look at some of the elimination exemplars, bladder dysfunction, urinary tract infections, and bowel dysfunction. The two specific bladder dysfunctions we're going to look at are urinary incontinence and urinary retention. Okay, so let's talk about urinary incontinence. That is an involuntary urination. It's a symptom and it's not a disease. It's the most common manifestation of impaired bladder control. It can have a significant impact on the patient's life, creating physical problems such as skin breakdown and leading to psychosocial problems, including embarrassment, isolation, ineffective coping, and social withdrawal. The incidence of urinary incontinence is estimated to be between 10 million and 13 million individuals in the United States and 200 million individuals worldwide. The estimated annual cost of managing urinary incontinence in the United States is 16.3 billion, 75% of which is spent on treating women. Although urinary incontinence is especially common among older patients, it is not a normal consequence of aging and it can be treated. An estimated 30% or more of older women living in the community experience urinary incontinence. In long term care, assisted living, and homebound populations, the incidence is between 50 and 80%. Despite these statistics, the actual prevalence of urinary incontinence is nearly impossible to determine. Embarrassment and the availability of products to protect clothing and prevent detection contribute to patients not seeking evaluation and treatment for incontinence. On page 1046 in your book, your Lewis book, there is a box that specifically talks about men and women. Men, it is a common manifestation of BPH and prostate cancer, and they're more likely to have the overflow incontinence caused by urinary retention. For women, prevalence of um, urinary incontinence is higher in women than men, and it's more likely to have they're more likely to have the stress and urge incontinence than men. Let's discuss the pathophysiology and etiology of urinary incontinence. Urinary continence requires a bladder that is able to expand and contract and sphincters that can maintain a urethral pressure higher than that of the bladder. Incontinence results when the pressure within the urinary bladder exceeds urethral resistance, allowing urine to escape. Any condition causing higher than normal bladder pressures or reduced urethral resistance can result in incontinence. Three examples of conditions that can cause higher than normal bladder pressures are: 1, the increased volume of urine in the bladder from use of diuretics; 2, the growing size of the uterus during pregnancy that puts pressure on the bladder; and 3, a weakened urethral sphincter related to decreasing levels of estrogen during menopause. Relaxation of the pelvic musculature, disruption of control related to cerebral or neuronal dysfunction, and disturbances of the bladder and its musculature are also common contributing factors. Incontinence may be an acute, self-limiting disorder, or it may be chronic. It may be congenital or acquired, reversed or irreversible. Urinary incontinence is acute and reversible if it is associated with partial or complete resolution. Reversible factors include polyuria, exposure to irritants, urinary retention, stool impaction or constipation, restricted mobility or dexterity, psychological conditions, delirium, medications like the use of diuretics or sedatives, and UTI. Some causes of urinary incontinence, such as acute confusion, may or may not be reversible, depending on the underlying cause of the confusion. Chronic or irreversible causes of urinary incontinence are often associated with congenital or nervous system disorders. Congenital disorders associated with incontinence includes absence of the upper wall of the urethra and a neural tube defect in which a portion of the spinal cord and its surrounding meninges protrude through the vertebrae column. Central nervous system or spinal cord trauma, stroke, or chronic neurological disorders, such as multiple sclerosis and Parkinson's disease, are examples of acquired irreversible causes of incontinence. There are several different types of urinary incontinence. In your book on page 1047, table 45.16, I would certainly review that so that you know the differences. Stress incontinence is the relaxation of the pelvic musculature and weakness of the urethra and surrounding muscles and tissues that lead to decreased urethral resistance. So this can be like a small amount of urine that is expelled when like sneezing, coughing, lifting, that kind of thing. So then there's urge incontinence. This condition usually results from a hypertonic or overactive detressor muscle, leading to increased pressure within the bladder and inability to avoid voiding. So this can be associated with involuntary loss of urine associated with a strong urge to void, increased rate of urination, inability to avoid urinating until a bathroom is available, and that overactive detressor muscle and nocturia. So reflex incontinence, this condition results from disruption to the neuronal control, and this is complete emptying of the bladder at a predictable bladder volume. Neurological defects, the frequency, nocturia, inability to sense full bladder or initiate or inhibit voiding. Overflow incontinence, this condition results from outlet obstruction or lack of normal detressor activity, leading to overfilling of the bladder and increased pressure. Loss of urine associated with overdistended bladder and urinary retention, urinary obstruction, and BPH. That's where the overflow incontinence usually occurs. Functional incontinence, this is a condition that results when the ability to respond to the need to urinate is impaired. This is usually seen in like dementia, some physical disabilities, patients with impaired mobility. And so loss of urine associated with physical impairments that prevent the patient from reaching the toilet in time, such as mobility impairment or those cognitive deficits. Some of the diagnostic tests to evaluate for urinary incontinence will be like bladdery diaries, a urinalysis, and blood tests. They're commonly used for patients experiencing urinary incontinence. The bladder diary is used to record how much the patient drinks, when the patient urinates, and how much urination is produced. If the patient felt the urge to urinate, how many incontinence episodes the patient experienced, and what the patient was doing at the time of incontinence. The bladder diary can help the healthcare provider to distinguish between stress, urge, reflex, overflow, and functional incontinence, and is to understand the patient's bladder functioning. A urinalysis detects appearance, color, blood, infection, glucose, specific gravity, presence of stones, and other characteristics of urine to identify the underlying cause of incontinence, such as a UTI or calculi. Various blood tests likewise will identify potential hormonal or chemical causes of incontinence, such as diabetes mellitus. Other urine tests that may be used for patients with urinary incontinence are a 24-hour urine sample, post-void residual measurements, urodynamic testing, and a stress test. The 24-hour urine sample reveals the volume of urine a patient produces in one day, and various tests are performed to provide data about kidney and bladder function. The post-void residual measurement shows the amount of residual urine left in the patient's bladder after voiding and bladder volume. A large post-void volume may indicate obstruction and nerve or muscle damage. Urodynamic testing measures the bladder pressure at rest and while filling. Filling is simulated by the insertion of a catheter and filling the bladder with water. This test measures bladder strength and urinary sphincter health. During a stress test, the patient is asked to bear down while the physician or nurse watches for urine loss. Imaging tests may also be performed to reveal the cause of urinary incontinence. A pelvic ultrasound is used to visualize structures in the pelvic region and any structural abnormalities. Cystography uses a radioactive dye inserted into the bladder through a catheter to show bladder abnormalities and post-void volume. In cystoscopy, the physician inserts a cystoscope to visualize the urinary tract, detect abnormalities, and obtain tissue samples to be sent for pathology tests. Many types of incontinence can be cured or improved. Most of the time, in general, less invasive treatments are used before more invasive treatments are utilized to try to help with that urinary incontinence. But remember, the choice of treatments is patient-centered and based on patient preference, the type and severity of any anatomical defects. So some of the things that are used are, for instance, like to reduce the incidence of urinary incontinence, you should teach your patient about pelvic floor muscle exercises, those Kegel muscle exercises, to improve that perineal muscle tone. Kegel exercises are most often used for women with urinary incontinence, but they may also benefit men who are experiencing urinary incontinence following a prostatectomy for BPH or prostate cancer. Assistive devices such as vaginal cones and biofeedback may be useful for patients who have difficulty identifying appropriate muscle groups. So in your book on page 1048, on 1046, there's a section talking about biofeedback, so you might want to review that. In addition, on page 1048, there is a chart, table 45.17, that identifies the interventions that are used for urinary incontinence. Some behavioral modifications is a classic method for treating urinary incontinence. Behavioral techniques include scheduling toileting, habit training, and bladder training. So scheduled toileting is toileting at regular intervals, such as like every 2 to 4 hours. Habit training is toileting the patient on a schedule that corresponds with a normal pattern. Bladder training gradually increases the bladder capacity by increasing the time between voiding intervals and resisting the urge to void between scheduled times. Bladder training may also involve double voiding or voiding once and then voiding a few minutes later to release residual urine, regulating fluid intake, avoiding dietary bladder stimulators, and performing relaxation and distraction techniques to overcome the urge to void. Excuse me. Additional non-pharmacological methods of treating urinary incontinence include using absorbent products such as pads or adult briefs, using a catheter. Let's see, a urethral insert is like a tampon-like device that is inserted into the urethra to act as a plug for leaks. A bladder support is made of flexible silicone and inserted into the vagina. It is shaped to support the bladder to decrease stress incontinence. Urethral inserts are usually used during specific activities that may cause incontinence. Catheters are used for patients with overflow incontinence due to bladder retention or for patients with neurological damage that affects bladder muscle control. Inter- Intermittent self-catheterization is the preferred catheterization method because it significantly decreases the risk of developing a UTI. If the patient is unable to perform self-catheterization or has no control of bladder muscles, an indwelling Foley catheter or subpubic catheter may be necessary. Just remember that use of any type of catheter increases the risk for a UTI. Okay, for some drug therapy or medications that are used to treat urinary incontinence, I would tell you to look on page 1050 in your book. Table 45.19 highlights the different medications. So, both stress and urge incontinence may improve with drug treatment. Some medications target the underlying cause of urinary incontinence, such as alpha beta blockers. Um, these are used for men with BPH, and antibiotics are used for individuals with a UTI. So, of course, we would use those antibiotics so that it'll take away that urgency. Drugs that contract the smooth muscles of the bladder neck may decrease episodes of mild stress incontinence. So, like tofranol is like an antidepressant. That is an effective therapy. And again, you'll find that on your list. Just be cautious because these medications can make the patient drowsy or maybe dizzy, have an irregular heartbeat. So you want to limit the use of any type of like antidepressants. When incontinence is associated with postmenopausal women, sometimes they're given like estrogen creams or local creams that can help with that. Patients with urge incontinence may be treated with preparations that increase bladder capacity. The primary drugs that are used to inhibit detressor muscle contractions and increase bladder capacity are like the oxybutynin and anticholinergic drugs. So those are often used, and sometimes they're taken once or twice a day. They have fewer side effects than less specific anticholinergic drugs. Drugs with anticholinergic effects are contraindicated for patients with acute glaucoma, and urinary retention is a potential side effect that must be considered when these types of drugs are used. Another drug that's also used is Botox, and that helps to treat urinary incontinence when the detressor muscles are overactive. So then we have some surgical interventions that we can also utilize, and they may be used to treat that stress incontinence associated with a prolapsed bladder or a prolapsed urethral and overflow incontinence associated with an enlarged prostate gland. Sometimes men get that prostatectomy using either the transurethral or suprapubic approach. It's indicated for a male patient who is experiencing overflow incontinence as a result of an enlarged prostate gland and urethral obstruction. Other surgical procedures of potential benefit in the treating of incontinence are implantation of artificial sphincter, formation of a urethral sling to elevate and compress the urethra, augmentation of the bladder with bowel segments to increase bladder capacity, implementation of nerve stimulators, and injection of collagen along the urethral to narrow the urinary passageway and support more normal urethral positioning. It's important to recognize both the physical and emotional problems associated with urinary incontinence. Maintain and enhance the patient's dignity, privacy, and feelings of self-worth. This involves a two-step approach with containment devices to manage existing urinary leakage and a definitive plan to reduce or resolve the factors leading to urinary incontinence. Management options are reviewed in your tables 45.17 and 45.18 in your book. They include lifestyle interventions such as teaching the patient about consuming an adequate volume of fluids and reducing or eliminating bladder irritants, particularly caffeine and alcohol from the diet. Have the patient maintain a regular, flexible schedule of urination, usually every 2 to 3 hours while awake. Advise patients to quit smoking because this habit increases the risk for stress incontinence. Teach patients about the relationship among constipation, urinary incontinence, and urinary retention. Aggressive management of constipation is recommended. Begin with ensuring adequate fluid intake, increasing dietary fiber, lightly exercising, and judiciously using stool softeners. Behavioral treatments include scheduled voiding regimens, bladder retraining, and pelvic floor muscle training. Assess how the patient contains urine and offer alternative devices when indicated. Many women use feminine hygiene pads. Many men and women may use household products such as rags, paper towels, or folded toilet paper. Unfortunately, none of these products are designed to wick urine away from the skin, preventing soiling of clothing and reduce or eliminate odor. Provide information on products specifically designed to contain urine. For example, patients with mild to moderate urinary incontinence often benefit from incontinent pads containing supra-absorbent material designed to absorb many times its weight in water. You'll see those, I actually forget what the name of those are called, but they have uh, different products out that look like feminine pads, but they're actually used for urine leakage. Patients with higher volume urine loss or those with both urinary and fecal incontinence may need disposable or reusable incontinent protective underwear, briefs, or pads. So make sure that you talk to patients about those. Some of it can be that they're kind of self-conscious about wearing them, but talk to them about how it absorbs and how it can keep from having maybe like skin breakdown because of that urine or stool sitting against the skin. Urinary retention is the inability to empty the bladder. It is most common in men with BPH, but other factors also can contribute to urinary retention. Urinary retention can be acute, in which the patient is unable to urinate at all, or chronic, in which the bladder consistently contains a small residual volume of urine. Although urinary retention is less common than urinary incontinence, it can become a medical emergency if the patient is unable to void. When bladder emptying is impaired, urine accumulates and bladder becomes overdistended. Overdistension causes poor contractility of the detrusor muscle, further impairing urination. If the problem persists, more serious problems such as hydronephrosis or backflow of urine from the bladder to the kidneys can result. Either mechanical obstruction of the bladder outlet or a functional problem can cause urinary retention. BPH is a common leading cause men have it seeking medical care with complaints of difficulty urinating and maintaining the flow of urine. Acute inflammation associated with infection or trauma to the bladder, urethral, or perineal tissues may also interfere with bladder elimination. Scarring caused by repeated UTIs subsequently leads to urethral stricture and produces mechanical obstruction. Although renal calculi at any location in the urinary tract can cause urinary retention from obstruction, calculus in the bladder may block the opening to the urethra. The unintended effects of anesthesia may cause individuals to experience urinary retention perioperatively. Side effects from various routine prescriptions and over-the-counter medications can also contribute to urinary retention. The same diagnostic studies used for urinary incontinence are also used for urinary retention. So the urinalysis, that post-void residual, the urodynamic studies, and ultrasound. And just as we did with patients with um, UI, we would do a lot of the behavioral therapies, such as that scheduled toileting, um, catheterization, either intermittent or indwelling, and then the same drug therapy. So you can refer to those specific charts that we talked about in the UI section. Surgical interventions are used to manage urinary retention caused by obstruction. Transurethral or open surgical techniques are used to treat benign or cancerous prostate enlargement, bladder neck constricture, urethral strictures, pelvic restructuring. Using an abdominal or transvaginal approach can correct bladder outlet obstruction in women with severe pelvic organ prolapse. While surgery has had a minimal role in the management of urinary retention caused by deficient detrusor contraction strength, a few new procedures may be a benefit. Sacral neuromodulation involves a simulator device and placement of a lead wire into the S3 foramen. Placement of an intraurethral valve pump, which empties the patient's bladder on command, may also be an option. There are several different catheters that you should be familiar with. The urethral catheterization is the most common route that we use, and it involves the insertion of a catheter through the external meatus into the urethra, past the internal sphincter, and into the bladder. These are usually placed into the renal pelvis. The catheter is either inserted by being threaded up the urethral and bladder to the ureters under cystoscopy observation, or by surgical incision through the abdominal wall into the ureters. Suprapubic catheters is the simplest and oldest method of urinary diversion. There's two methods for insertion of these particular catheters. One is through a small incision in the abdominal wall, and the second is using a trocar. Acute urinary retention is a medical emergency that requires prompt recognition and bladder drainage. Insert a catheter as ordered. So many a times we use those indwelling catheters. Teach the patient with acute urinary retention and the patient predisposed to these episodes ways to minimize risk. So you tell them to drink small amounts throughout the day and avoid the intake of large volumes of fluid over a brief period of time. So you certainly don't want them to go like chug a gallon of water or something. Tell the patient that if they're, kind of feeling cold or something like that, to try to warm up before voiding. That would help initiate that. They should avoid excessive alcohol, as that leads to polyuria and a diminished awareness of the need to void until the bladder is distended. You're going to also talk to them and teach them about increasing caffeine, like coffee or soda, tea, things like that. And that creates a maximum urinary urgency. Tell patients that sitting in like a warm bathtub or taking a warm shower may actually help them void. You remember back when you used to like I don't know, like if you had a sleepover at somebody's house when you were super young and you put their fingers into warm water and then they would pee while they were sleeping. It's the same kind of concept. So those are things that we would talk to the patient, teach the patient, and that we would actually do for those patients that have that acute urinary retention. Of course, if none of those things work that we're telling them, they absolutely need to seek that medical care. Okay, so for our patients that have that chronic urinary retention, a lot of it is behavioral methods that we use. We use the indwelling or intermittent catheterization. Sometimes it's surgery, and sometimes it's medications. We can help with that scheduling, toileting, and like that double voiding. So they would urinate, and then 1 or 2 minutes later, they'd void again for any residual. We would also use that scheduling toileting to reduce rather than expand the bladder, right? So we don't want them to hold it. So if we're taking them to urinate every 2 to 3 hours, then we're kind of decreasing, especially those over distended bladders for people who have things like chronic over distension, diabetes, or if they have alcoholism. So they typically will have a diminished or delayed sensation of bladder filling and urgency. So taking them and toileting them every 2 to 3 hours or 3 to 4 hours, that would allow them to go ahead and get somewhat on a schedule, and it will decrease the bladder capacity. Right, so let's move on to urinary tract infections. So these are very common infections in women. Um, there's different causes for them, specifically like E. coli. We see that in the Candida albicans because of the indwelling catheter. Fungal and parasitic are pretty uncommon, although we do see them in some of our immunocompromised patients. So that does affect them. However, we do see it more common in women um, than in men. So just FYI, like if you have a patient, for instance, that you're caring for on the unit, and um, yesterday you were working with them, or earlier that day you were working with them, and neurologically they were, completely with it. Sometimes, a little confused, but not really. And all of the sudden, as the day progresses, you see a change in their behavior, their neurological status, as far as maybe they're hallucinating or something like that. It could actually be signs of a urinary tract infection. I had a patient that actually um, thought that she had like bugs crawling in her room and on her skin, which was a complete change of behavior than what she was like earlier in the day. When we ended up testing her urine to see if she actually did have bacteria in the urine and a UTI, it was the case. And as soon as the patient was on medication, they then started to come back and not have those hallucinations. So just be mindful that if you see that, it could be an indication that a patient is potentially getting a UTI or has a UTI. There are different classifications of UTIs. They can be bacterial, viral, or fungal, and may be categorized in different ways. UTIs may affect the lower or upper urinary tract. Infections of the lower urinary tract include uretitis, inflammation of the urethra, and cystitis, inflammation of the urinary bladder. The most common upper UTI is pyelonephritis, which is inflammation of the kidney and renal pelvis. Urosepsis is a UTI that has spread systemically and requires immediate medical treatment. This is when an untreated UTI spreads to the kidney. It is a form of sepsis. UTIs are defined as community acquired or healthcare associated, like when a patient has been catheterized or insertion of a Foley catheter that causes an infection. They can also be classified as complicated or uncomplicated. Uncomplicated occurs in an otherwise normal urinary tract and usually only involves the bladder. Complicated occurs due to functional or structural problems in the urinary tract. So we'll see this with our patients who have kidney stones. Maybe they have obstructions, acute kidney injury, or our chronic injury or chronic kidney injury patients. This figure kind of shows you a little bit of where the sites of the infection actually occurs in the upper and lower urinary tract. So those specific ones like polynephritis and cystitis that we were just talking about, you can kind of see where those actually occur within the urinary tract system. The urinary tract is normally sterile above the urethra. Adequate urine volume, a free flow from the kidneys through the urinary meatus, and complete bladder emptying are the most important mechanisms of maintaining sterility. Pathogens that enter and contaminate the distal urethra are washed out during voiding. Antibacterial characteristics of urine are maintained by an acidic pH less than 6.0, high urea concentration, and glycoproteins that interfere with the growth of bacteria. Any change in any of these defense mechanisms increases the risks of UTIs. A variety of factors can predispose patients to UTI. Some risk factors cannot be changed, like aging and a woman's short urethra. Cystitis occurs most frequently in adult women, usually because of colonization of the bladder by bacteria that are normally found in the lower gastrointestinal tract. These bacteria gain entry by ascending the short, straight female urethra. So this is where we would teach patients about wiping from front to back and not back to front. Urinary stasis increases the risk of UTIs. Stasis may be caused by abnormal anatomic structures or abnormal functions. Children typically void 5 to 6 times a day. Infrequent voiding, which is common in school-aged children, results in incomplete emptying of the bladder and urinary stasis. So even for us nurses, we hold urine a lot because of how busy we are, and we have a tendency not to void when we need to because we're busy, and that urinary stasis causes UTIs. Congenital and acquired factors that contribute to the risk of infection include urinary tract obstruction by tumors or calculi, maybe an impaired bladder nervation, bowel incontinence or constipation, and chronic diseases such as diabetes mellitus. So, let's see, in women, including adolescents, sexual activity increases the risk for UTIs because bacteria can be introduced into the bladder via the urethra during sexual intercourse. So this is why we talk to our patients a lot about voiding, our female patients, voiding after intercourse because it helps to get rid of some of that bacteria. So the etiology and pathophysiology of UTIs. Pathogens usually enter the urinary tract by ascending from the mucous membranes of the perineal area into the lower urinary tract. Bacteria that have colonized the urethra, vagina, or perineal tissues are the usual source of infection. From the bladder, bacteria can continue to ascend the urinary tract, eventually infecting the parenchyma of the kidneys. Hematogenous spread of infection to the urinary tract is rare. Infections introduced in this manner are usually associated with previous damage or scarring of the urinary tract. Bacteria introduced into the urinary tract can cause asymptomatic bacteremia or an inflammatory response with manifestations of UTI. At least 10 to 15% of hospitalized patients with indwelling urinary catheter develop bacteremia. The longer the catheter remains in place, the greater the risk of infection. Bacteria, including like E. coli, reach the bladder either by migrating through the column of urine within the catheter or by moving up the mucosal sheath of the urethra outside the catheter. Catheter-associated urinary tract infections, they're also called CAUTIs, have become a major healthcare concern and is one of the major HAIs. Bacteria enter the catheter system at the connection between the catheter and the drainage system or through the emptying tube of the drainage bag. Colonization of perineal skin by bowel flora is a common source of infection in catheterized women. Because the Centers for Medicare and Medicaid Services no longer reimburse for CAUTIs, healthcare institutions are highly motivated to decrease CAUTI rates nationally. All right, so let's look at the lower urinary tract symptoms. These occur in patients who have UTIs of the upper urinary tract as well as those confined to the lower tract. Symptoms are related to either bladder storage or bladder emptying. In your book, page 45.3 goes over some of the lower urinary tract symptoms. And showing you that they are grouped up into either the emptying symptoms or the storage symptoms. These could potentially include dysuria, frequency, voiding more than every 2 hours, that urgency, and suprapubic discomfort or pressure. The urine may contain grossly visible blood, hematuria, or sediment, giving it somewhat of a cloudy appearance. And oftentimes, um, these manifestations are confused with just a regular UTI. Infection of the upper tract typically causes fever, chills, and flank pain. Sometimes patients are asymptomatic and they will present with stating that they have fatigue or potentially anorexia. Um, Remember that the clinical manifestations of a UTI are often absent in older adults. So oftentimes these older patients will have non-localized abdominal discomfort and do not present with a fever. So asymptomatic bacteremia is only treated for patients that are pregnant or are undergoing urological treatments. Okay, so some of the diagnostic tests, urinalysis assesses for polyuria, bacteria, and blood cells in the urine. Rapid tests for bacteria in the urine include using a nitrate dipstick, which turns pink in the presence of bacteria, and the leukocyte esterase test. It's an indirect method of detecting bacteria by identifying lysed and intact WBCs in the urine. Urine should be obtained as a midstream clean catch. If necessary, use straight catheterization or mini cath with strict aseptic technique. Avoid catheterization if possible to reduce the risk of further infection. Urine from urine collection bags may be used to screen for UTIs in infants, but it cannot be used to confirm a UTI and should not be used for most patients because the specimen collection procedure is not sterile. Gram stain of the urine may be done to identify the infecting organisms by shape and characteristics. Urine culture and sensitivity test may be ordered to identify the affecting organisms and the most effective antibiotic. Urine specimens collected for culture must be delivered to the laboratory within 1 hour, or the specimen must be refrigerated to prevent the growth of organisms that occur with prolonged room temperature exposure. Culture requires 24 to 72 hours, so treatment to eliminate the most common organisms often is initiated without culture. Urine cultures do not distinguish between upper and lower UTIs. WBC count with differential may be done to detect the typical changes associated with infection. So if we have patients with recurrent infection, um, they'll order some additional diagnostic testing to evaluate the structural abnormalities, renal scarring, and other contributing factors. So there's the IVP, intravenous pylography. It's used to evaluate the structure and excretory function of the kidneys, ureters, and bladder. They'll do like a voiding test, which involves instilling contrast medium into the bladder and then using x-rays to assess the bladder and urethra when filled and during voiding. Cystoscopy, so that gives them direct visualization of the urethra and of the bladder through a cystoscope. And sometimes it'll be with manual pelvic or prostate examinations to assess for structural changes, and renal and bladder ultrasound. They're used to detect pyelonephritis and renal scarring. So diagnosis of a patient with a UTI, we're going to look at their history and physical, UA results, culture and sensitivity, and any imaging that the patient has had and it's resulted. So our management for our uncomplicated patients, we're going to teach them about adequate fluids. Sometimes patients will have like cranberry juice because it helps with the kidney function. Um, Phenazopyridine and antibiotics are generally used to help. Um, Phenazopyridine, sorry, also helps with the symptoms of UTI, so like that urgency and pain when urinating. So if a patient has recurrent UTIs, obviously the same applies to the above. We're going to do that same patient teaching and the same drug therapy, but they may look for a longer span of antibiotics. Instead of the 3 days, we're going to look at 7 to 14 days or potentially longer because they have that propensity to have that infection again. Most uncomplicated infections of the lower urinary tract can be treated with a short course of antibiotic therapy. Upper UTIs, in contrast, usually require longer treatment, 2 or more weeks to eradicate the infecting organisms. Treatment should be initiated as soon as the UTI is diagnosed. Antibiotics are selected based on the age of the patient, the sensitivity of the cultured organism, renal function, and the patient's signs and symptoms. Gender is a consideration in treatment choices because men require longer periods of treatment than women. The longer urethra in men makes it less likely that bacteria can ascend into the bladder. However, when bacteria do reach the older man's bladder, the infection is considered complicated and requires a longer course of treatment. The antibiotic is changed if necessary after culture sensitivity is determined. Short course therapy, either a single antibiotic dose or a 3-day course of treatment, reduces treatment cost, increases compliance, and has a lower rate of side effects. Single dose therapy is associated with a higher rate of recurrent infection and continued vaginal colonization of E. coli, making a 3-day course of treatment the preferred option for uncomplicated cystitis. Oral SMP, SMZ, or Cipro, or even Pentatrex may be ordered. Men and women with pyelonephritis, urinary tract abnormalities or stones, or a history of previous infections with antibiotic-resistant infections requires a 7 to 10-day course of TMP, SMZ, Cipro, or even alternative antibiotics. Patients with severe illness may need hospitalization and IV antibiotics such as Cipro, gentamicin, Rocephin, or amoxicillin may be prescribed for severe illness or sepsis associated with UTI. Subjective and objective data that should be obtained from a patient with a UTI are shown in your table on page 1027, table 45.5. I would review that. Your observation and patient interview, you're going to observe the skin color of the patient and observe for indications of discomfort. Note the color, clarity, and odor of urine. Interview the patient about current symptoms, including urination frequency and urgency, burning on urination, and the number of voidings per night. Ask the patient about other manifestations such as lower abdominal, back, or flank pain, nausea or vomiting, or fever. Have the patient describe the duration of symptoms and any treatment attempted, as well as a history of previous UTIs and their frequencies. With women of childbearing age, including adolescents, ask about the possibility of pregnancy and type of birth control used. Last, ask the patient about chronic diseases such as diabetes, current medications, and any known allergies. Examine the patient's general health and collect vital signs during your physical examination, including the temperature. Examine the patient's abdominal shape, contour, and tenderness to palpation. In addition to the subjective data that I covered on the previous slide, you're also going to get objective data and you're going to look at their general appearance. I kind of covered that on the previous slide. But you also want to review the possible diagnostic findings. So if the patient had a urinalysis or any type of diagnostic testing, culture and sensitivity, things like that, you want to review those during your assessment. Nursing diagnoses for patients with UTIs focus on comfort, urinary elimination, and teaching learning needs and may include acute pain, urinary elimination impaired, deficient knowledge, urinary retention, fluid volume deficit, or fear. In planning and implementing nursing care for the patient with a UTI, the patient's general health, abilities for self-care, and risk factors that may contribute to UTI are considered. Outcomes developed in collaboration with the patient may include the patient will describe pain as a 3 or lower on a 0 to 10 scale. The patient will regain normal voiding pattern and will produce normal urine without blood, bacteria, or protein. The patient will verbalize understanding of the disease process, proper method of taking medications, and required follow-up care. The patient will describe strategies for reducing the risk of another UTI. The patient will increase fluid intake and number of voidings each day. The patient will complete the prescribed course of antibiotic therapy. The patient will experience no recurrent UTIs for 1 year. The patient will incorporate and preventative self-care measures into their daily regimen. It is important to recognize people who are at risk for a UTI. These include debilitated patients, older adults, patients who are immunocompromised because of cancer or diabetes, and patients treated with immunosuppressive drugs or corticosteroids. Health promotion activities can help decrease the frequency of UTIs and provide for early detection of infection. These activities include teaching preventative measures, including emptying the bladder regularly and completely, evacuating the bowel regularly, and wiping the perineal area from front to back after voiding and defecation. And finally, drinking an adequate amount of liquid each day. All patients undergoing catheterization of the urinary tract are at risk for developing CAUTIs. You, as the nurse, play a pivotal role in preventing CAUTIs. How? Well, avoiding unnecessary catheterization and that early removal. So when the patient meets the criteria to remove it, then we do so. We don't leave them with um, catheters, Foley catheters, just because it makes our life easier. We need to remember that it is a significant reason why patients end up with UTIs. So when you're inserting, you always need to follow your aseptic technique. Make sure that you keep your sterility. If you don't, if you break your sterile field, start over. It's not worth the potential for a patient to get a UTI because you're rushing or that you think it just won't matter. Make sure that you wash your hands before and after contact with each patient and wear gloves when you care for a urinary catheter, when you're doing that urinary catheter care and cleaning it. That is a huge component of making sure that a patient does not endure infection, a UTI infection. The American Nurses Association has an evidence-based tool for decreasing CAUTIs. So it's important that you review that and you use that, but specifically make sure that you understand that you as the nurse play a pivotal role in whether or not a patient um, ends up with a UTI because of a catheter. Acute care for a patient with a UTI includes increasing or making sure that they have adequate fluid intake. Now, for some patients, they may find that they don't want to drink a lot because that then prompts them to have to void, and therefore they might experience that discomfort or that pain. But it's really important because the more they urinate, the more they flush out that bacteria, and it's less likely to colonize. You also want to tell the patients to avoid things like caffeine, alcohol, citrus juices, chocolate, and highly spicy foods because they are a bladder irritant. If the patient is having a suprapubic or lower back pain, you can do the warm shower or a bath, or you can actually put like a, a heating pad to help with that discomfort. So some of their patient teaching, you want to make sure that you discuss all the medications and the potential side effects. Um, Advise the patient that they need to complete their prescription regimen because stopping the medication just because they start to feel better could prompt them to have a reoccurrent UTI. Um, Sometimes a second drug or a reduced dosage of drugs is given after the first course to suppress bacterial growth in the patients. So teach them about monitoring signs of of improvement, or are they deteriorating. So if they start having odor in their urine, if their urine is cloudy, if they're experiencing more of that discomfort when they're urinating, those are things that they need to report back to the physician so that they can then get on antibiotics, maybe different antibiotics, in order to get rid of that infection. So many of our patients are cared at home with UTIs, and it's our job to um, emphasize the importance of adhering to that drug regimen. It's our responsibility to talk to them about how to take their antimicrobial drugs as ordered, maintaining that adequate fluid intake, void regularly and before and after intercourse. And if a patient is using a diaphragm, you want them to temporarily not use that. In your book on page 1028, table 45.6, really goes over the patient and caregiving teachings for a urinary tract infection, and it really highlights and puts it all into a neat little table for you guys to review. So make sure you take a look at that. So the expected outcomes for our patients with UTIs, obviously we want them to have a normal urinary elimination problem. And the outcome of treatment for UTIs may be determined by follow-up urinalysis and culture. Cure, as evidenced by the absence of pathogens in the urine, is the desired outcome. Many of our patients, uh, after they have completed their antibiotic regimen, um, they are generally required to submit a urinalysis for culture 7 to 10 days after completing a course of antibiotics to ensure that bacteria have been eliminated. Constipation is characterized by the passage of fewer than 3 bowel movements per week or by difficulty in passing stools. Manifestations of this condition may include the absence of stool passage or the passage of dry, hardened stool. In most cases, constipation is due to decreased motility and slow movement of feces through the large intestines. Constipation may reflect a primary problem or it may indicate an underlying disorder. Risk factors associated with chronic constipation include a low fiber diet, decreased physical activity, or ignoring the defecation urge. Ignoring the urge to defecate for a prolonged period can cause the muscles and mucosa of the rectum to become insensitive to the presence of feces. In addition, the prolonged retention of feces results in drying of stool due to water absorption. The harder and drier the feces, the harder it is to expel. Emotions including anxiety, depression, and stress affect the GI tract and can contribute to constipation. Constipation occurs with diseases that slow GI transit and hamper neurological function. So, diseases such as diabetes, Parkinson's, and multiple sclerosis, they all contribute to that. There is a table 42.5. It is on page 930 that you can review that has a list of all the diseases that are associated with constipation. I'm sure you guys remember from your first semester when you did drug cards on opioids. They do cause constipation, so that's why we many a times will ask for a order for like um, not Docalax, Colace, for Colace so that it's a stool softener and it helps the patients to avoid constipation and they can pass the stool. Uh, Some people think that they are constipated if they don't have a daily bowel movement. I actually see this with a lot of our older population. They feel that if they don't have one every single day, that they're something's wrong, and so what they do is they end up taking laxatives almost on a daily basis so that they can go ahead and have a bowel movement. Unfortunately, this can cause the colon to actually become dilated and lose its muscle tone, and therefore they actually need a laxative because the body doesn't actually produce that defecation without the use of a laxative. So this is why we do a lot of patient teaching on not chronically using laxatives as a source of relieving what they feel is constipation. The manifestations of constipation, they range from mild to severe discomfort. Um, you'll see this with like straining with defecation. They feel like they have to push. It hurts. Therefore, they don't necessarily always want to go to the bathroom because of that. Those lumpy, hard stools, and they have that sensation of incomplete emptying. Um, and again, like we stressed earlier, fewer than 3 bowel movements per week. Patients who are constipated, they have that abdominal distension. They feel like their stomach just hurts. They feel uncomfortable. There's a lot of gas, a lot of bloating. And so it also increases that rectal pressure. Uh, Hemorrhoids come from constipation primarily. Women also get them when they have babies. But hemorrhoids occur because of that straining and that increased pressure that's put onto the rectum to try to pass those hard stools. And diverticulosis we see in older patients. Fecal impaction And, that constipation can actually cause a perforation in the colon, and therefore, that's a rip in the colon, and they end up having to have surgery because of that. So, those are some of the manifestations that you see. Impaction is a mass or collection of hardened feces in the folds of the rectum. Um, it's really from that prolonged retention and accumulation of fecal matter that has not been expelled, and over a period of time, it just continues to dry up, dry up, dry up, and therefore it gets impacted, and the patient cannot pass it. So, some of those clinical manifestations that you'll see is like liquid. It actually, what happens is new um, feces is liquidy because it doesn't have the ability to form. It passes through the impaction and it just drips out. So patients actually have like a fecal incontinence. If they have like a foul smelling material with no form stool, if they have abdominal distension, they might have vomiting. Um, they might have um, like abdominal cramping. So what do we do about it? Well, first we take a look at it. Maybe we might do a digital examination where we actually have to go into the rectum to feel if there is an impaction. Sometimes they'll use an abdominal X-ray to visualize that. And the reasons patients have it is because of their laxative dependence, maybe a barium swallow that they had to have for testing purposes. And what we do to treat it is sometimes manually remove it, might be necessary. It is extremely painful for patients and very uncomfortable. We also administer enemas, and then we kind of teach the patient about increasing fluid and fiber intake, stool softeners, and if they can increase their activity to prevent that reoccurrence. In most patients, the diagnosis of constipation is based on findings from a thorough history and physical examination. The physical should include an abdominal examination, inspection of the perianal and rectal region, and a digital rectal examination. So you're going to make sure that when you complete your assessment that you look at those areas, look for any findings that cause concern. We're also going to look at if a patient has a new change in their bowel patterns that has happened in the last 6 weeks. Do they have bleeding? Is the rectal bleeding? Is it bright red? Is it um, like coffee ground looking? Is the patient and their labs, do they have anemia? Is there a significant weight loss? Some pain, personal or family history of maybe colorectal cancer or irritable bowel disease, and if you feel any type of masses or anything like that. So a lot of your information that you're going to get with the constipation is going to be based upon your findings and your conversations with your patients. So some of the like some of the testing and diagnosis that we look for, our diagnostic testing is through those x-rays and a barium enema colonoscopy, where they actually get to go up through the rectum and the camera and look at the intestines, the colon area, to see if there's any concerns or issues, polyps, obstructions, anything like that. Sometime a balloon expulsion and can also be used. So these are things that we look at as that we're going through of our diagnostic studies for our patients that have constipation issues. Okay, so some of our interprofessional care that we can provide to these patients and patient teaching is that we're going to tell them about increasing their dietary fiber, their fluid intake, and getting some exercise. That will help with their constipation problems. Sometimes we end up giving them laxatives, and that depends on the severity and the duration of the constipation and also the patient's health. So, daily bulk forming laxatives can prevent constipation because they work like dietary fiber. And the nice thing about them is they don't cause dependence. So, if a patient has chronic constipation and they do not respond to that diet and lifestyle modifications, osmotic laxatives are the next recommended treatment. Stimulant laxatives are given to patients who do not respond to osmotic laxatives. Enemas, they're fast acting. As soon as they take them, they usually have some type of relief of that constipation. And let's see, agents containing um, sodium phosphate and magnesium can cause electrolyte imbalances, so we need to be a little bit careful about that. Patients with severe related constipation related to bowel motility or mechanical disorders, they require a little bit more intense treatment. So we might do some GI tract transient studies so that we can see what the reasoning for it is. And if they continue to have that unrelenting constipation, they may actually need a colostomy or an ileostomy or a continent fecal diversion. So those are different surgeries that can occur with those patients. We see them in the hospital quite a bit with the colonoscopies. Sometimes they're permanent and sometimes they're for a certain period of time. But that kind of depends on the patient's health and what the underlying cause is. Some of that nutritional therapy. So, that's a key factor in preventing constipation. So, we want to teach our patients about increasing their fiber intake, um, things like fruits, vegetables, and grains. There's a chart 42.8 in your book that describes some of the dietary recommendations to help with constipation. Um, Dietary fiber adds to stool bulk directly by attracting water. So you want to make sure that you have that patient realize that they need to have adequate fluid intake of about 2 liters a day. In your book, it also, on page 931, there's an evidence-based practice related to the use of probiotics. Probiotics really do improve the the amount of time that it's in the gut, the stool frequency, and stool consistency. So I would review the evidence-based practice related to probiotic as well. During your nursing assessment, you're going to get that subjective data. So, you're going to ask about their past health history. Do they have any history of colorectal cancer? Um, Neurologic dysfunction, bowel obstruction, cancer, irritable bowel disease, or diabetes. You're going to ask them about their patterns of um, bowel movements. How often, how frequent, um, any changes. Do they have to use, or do they feel like they have to use any type of laxatives or enema usage? You're going to ask them about, is it difficult for them to pass stool? Do they feel like it's the amount of stool that they are passing has decreased or increased, anything like that? Ask them about their abdominal distension. Um, do they feel like any pressure in their abdomen? A lot of gas? Do they have um, an activity regimen? Do they get continuous or daily exercise in some way? Um, you're going to ask them about their stress levels, things like that. Then you're going to use that objective data and look at their general appearance. Do they have lethargy? When you look at doing your actual physical assessment and you look at the integumentary, do they have any hemorrhoids? Are there any abscesses? Do they have that abdominal distension? Are the bowel sounds hypoactive? So that's going to show us that maybe they don't have the motility happening. Um, do they have small, like, is it a large amount of stool passage? Is there blood in the stool? And so you're going to have to ask some questions and find out their patterns, because if you have a patient that says that they have a bowel movement once a day and they think they're constipated, then it might be some patient teaching that we need to provide to them. Maybe it's just that they're not completely emptying, or they feel like there's a problem where they're retaining some of their stool. Realize that your plan to help a patient who is having constipation is individualized, and it's really according to what their symptoms are. It's not kind of one size fits all, so you want to make sure that you individualize that plan. Um, you're going to need to, of course, again, we go back to educating the patient or the caregiver related to the importance of diet and fluid intake and exercise. Um, you know, a lot of our patients, maybe um, they have constipation issues because they ignore the urge to go because of their job, because of their life, because of those things. So you want to urge them to really get an elimination pattern on a daily basis. And try to, as much as they can, to avoid laxatives and enemas. The position that a patient takes, we see this in the hospital where we expect patients that are not able to get out of bed to defecate in the bed. And it's really difficult because that positioning is really important. And you need to make sure that if the patient does go to the commode, that their knees are higher than their hips, so that it can aid in that defecation and allow gravity to help. Sometimes I think they came out with some new type of footstool that you could use for pottying, and it helped. I think it was called like a poop stool or something like that, where patients had their feet up and it allowed for a much more natural positioning to promote defecation. Realize that patients need privacy, that if they can go into the bathroom and close the door, that they feel like they're kind of like it's not something that they want to do out in the open and in front of other people. They tend to get embarrassed because it's the odor in the room, things like that. So you want to make sure that you eliminate as much of that as possible, and that will also help with a patient who has constipation issues, or they're trying to get back on some type of bowel regimen. Okay, so fecal incontinence is the inability to voluntarily control the passing of fecal contents and intestinal gas through the anal sphincter. In most cases, fecal incontinence is a manifestation of another disorder. Numerous conditions may cause fecal incontinence, including neurological disorders, depression, traumatic injuries, or inflammatory processes affecting the bowel, and masses, hemorrhoids, or deformity in the anus. Episodes of incontinence may be unpredictable, or they may occur at specific intervals, such as following meals. For patients who experience fecal incontinence, embarrassment and shame may lead to social isolation. So a lot of our diagnostic studies are really primarily right along with a lot of the other bowel elimination problems. So you're going to look at their H&P and get that history, see if they have any type of history of colorectal cancer, anything like that. You're also going to do a rectal examination and look for any abnormalities in there. You're also going to look at We can use diagnostic studies such as ultrasound or electromyography so that we can look at the actual structure of the anus or the rectum area. Um, and then if a patient actually does um, have a stool, then you're going to look for like the color, the consistency, the shape, the amount, the odor, and the presence of abnormal constitutes. Treatment of incontinence depends on the cause. Maintaining normal stool consistency and a bowel management program are important. This includes regular defecation, a high fiber diet, and increased intake of caffeine free fluids. Dietary fiber supplements or bulk forming laxatives like Metamucil increase stool bulk, firm consistency, and promote the sensation of rectal filling. Patients may need to reduce the intake of foods that cause diarrhea and rectal irritation. Common triggers include caffeine, products containing artificial sweeteners, dairy products, high gas producing vegetables like broccoli, cabbage, cauliflower, and vegetables containing insoluble fiber like lettuce, tomatoes, or corn. Fecal incontinence from fecal impaction usually resolves after manual removal of the hard feces and cleansing enemas. Antidiarrheal agents are useful in slowing intestinal transit. Physical therapy and biofeedback training can improve awareness of rectal sensation, coordinate internal and external anal sphincters, and increase the strength of external sphincter contraction. Biofeedback training requires intact sensory and motor nerves and motivation to learn. It is a safe, painless, and effective treatment. Mild electrical stimulation of the sacral nerves targets communication problems between the brain and nerves that control the pelvic floor muscles and sphincters. Electrical stimulation can improve quality of life. Some patients may achieve complete continence. For patients who do not respond to conservative measures, treatment with Solesta may be used. In this treatment, the gel is injected into the deep submucosal of the patient's anal cavity. It works by building up tissue in the anal area, narrowing the anal canal, and allowing muscles to more accurately close. No anesthesia is given. Surgery, such as sphincter repair procedures, is an option when other conservative treatments fail. The patient has thick, a full thickness prolapse of the sphincter. Anal sphincter needs repair. A colostomy is sometimes needed. So during our nursing assessment, we are going to ask about previous and current bowel patterns, like has it increased, has it decreased, anything like that. What is that stool consistency? So there's a scale called the Bristol Stool Scale, and it identifies the different types um, of stool and what it would be classified as. So we also look at the volume. Are they defecating a lot? Are they passing a small amount of feces? Any type of symptoms that the patient is having? We're also going to ask them about their sensation of urgency to defecate or to pass flatus. So we would ask them if they, all of a sudden have like an increased urgency. Does something trigger that? So does this incontinence interfere with their daily activities? What's their diet? Are they avoiding certain foods? Does it make it worse? And is your incontinence causing any type of um, exclusion of activities or isolation issues? We're also going to take a look at the actual integumentary of the perineal area. Is there any type of breakdown? Is there irritation? Sometimes our patients, when they have incontinence issues, they do have the incontinence associated dermatitis. it's a IAD. This is caused because of that fecal matter staying on the skin, and it actually irritates it. So we want to take a look during our assessment and see if the patient has presence of any of that. What are some of the things that we can actually do as nurses? So we help with that bowel training program. We get the patients into the bathroom, and we help them to um, get on a regular pattern. So sometimes like 30 minutes after they have breakfast would be the best time to schedule that elimination. And you just consistently do that. If that's ineffective, sometimes we use like a glycerin suppository or maybe a small enema that will help stimulate um, for the patient to defecate, and therefore we can get a pattern more established. Sometimes we use digital stimulation, and then some tap water irrigation can also work to try to help the patient to get on a better bowel training program. All right, so it is certainly important for us to maintain that skin integrity for patients. It's definitely a priority because feces can contaminate wounds. They can damage skin, cause bladder infections, and actually spread infections like C. diff. So, um, we can use things like absorbent pads or briefs, and we can make sure that if a patient is incontinent, don't leave them in feces. Clean them up as quickly as possible to maintain that skin integrity, not, let alone their dignity. um, Use moisturizers and skin protectors. Most of the hospitals have some type of barrier cream that you can apply to a patient to try to keep the feces or liquid stool off of the patient so that it doesn't prompt that skin breakdown. It's important for us to educate patients. So that they can, reduce those episodes. They're very embarrassed about them, so you want to talk to them about looking for triggers, things like certain foods that cause them to have incontinence. Um, Avoid those foods. Uh, that would, be the easiest way for them to keep from having any of those issues. Avoid products that contain alcohol. Um, and you want to make sure that you realize just how overwhelming it is for patients. Um, if they have fecal incontinence problems, have them, wear dark clothes so that it's not seen. Have them carry an extra set of clothes, maybe some cleanup wipes, so that they could quickly address the issue. If they're not in the hospital, obviously, we would take care of it. But you definitely want to um, be empathetic to what the patient is going through and provide them some coping strategies for that.